they'll wander in and they're online. Yeah.
Right, but if you want, sometimes there's duplicate entry, you know, and then you want to do things like showing the outcomes for this mutation, for transplantation. Not very sophisticated.
No, I have no preference. You tell them that and they'll ask questions and then chats might come up. Where will we see questions on the chat? It'll come up on here? Okay. All right. Thank you. So we have people online? Okay. Good morning. I have chores to do before we get started. The first is to thank you for joining the Winship Grand Rounds this morning. And if you are an Emory University or healthcare employee and would like to receive a CME credit hour for attending today, the access code today is 398679 and can be found in the chat feature at the bottom of your screen for our virtual attendees. If you have any issues with the webinar or the CME login, please send Janelle Taylor an email or drop a note via the chat feature. Tour is done. Now, it is my pleasure to welcome my good colleague and friend, Dr. Karen Mustain. Dr. Mustain is the Dean's Distinguished Endowed Professor of Oncology and Surgery at the University of Rochester School of Medicine and Dentistry. She is also co-director of the Wilmot Cancer Institute Cancer Prevention and Control Research Program. She is co-director and MPI of the University of Rochester Cancer Center NCORP Research Base and director of the Human Performance Clinical Research Laboratory. Dr. Mustain is an internationally recognized clinical researcher in the areas of cancer control and survivorship with primary foci on investigating the influence of exercise such as yoga and Tai Chi on symptoms and side effects, acute and chronic late, and stemming from cancer and its treatments. In fact, she's one of the first in the world to publish on the effect of Tai Chi on cancer patients. Dr. Mustain is a leader in conducting large multi-center phase 3 clinical trials, testing exercise and behavioral interventions among cancer patients and survivors, with over 20 years experience at the University of Rochester Wilmot Cancer Institute. She's the PI for several local and nationwide randomized clinical trials funded by the NCI, DOD, NINR, and more. And she has outstanding funding and publication records, acquiring over 80 million in research funding, and this is old, so I'm sure it's more, and over 240 articles and book chapters. Dr. Mustain has been recognized for her excellence in research and leadership with more than 43 awards nationally and globally. She's also on the NCI Board of Scientific Advisors. Please welcome Dr. Mustain today for her talk in Era of Exercise and Integrative Oncology, Yoga Therapy, Cancer Treatment Toxicity, and Circadian Gene Expression.
So thank all of you for coming so early this morning, and those of you that are joining online for meeting us such an early hour. Thank you for the opportunity to visit Atlanta because it's much sunnier and warmer than where I am currently in New York. Although I hope I'm going back to warmer weather this time of year. So I'm happy as I move through this. I probably have way more slides than I should fathom that I can talk about in the next hour and have discussion on. So if you have a question, feel free to type it in the chat. And if you're here in the room, feel free to just ask as we go. I can take some questions as we go. And if they're all held to the end, that's fine too. So I always like to start by telling people why I started doing this type of research. So I'm formally trained as an exercise physiologist and an exercise psychologist. And when I started my career, I thought, like most everyone else in my profession, that I was going to work with elite athletes. And that's exactly what I started doing. I was consulting for the United States Olympic Committee, the International Olympic Committee. I was evaluating sport performance and how to enhance that performance from a physiological and a biomechanical perspective. And then two very important people to me in my life were diagnosed with cancer, both of my grandmothers, and I helped take care of them. So that was one pivotal point that got me interested in cancer. The second thing was that it was happening at exactly the same time in my life that as an exercise scientist, I discovered something that really was not very popularized in the United States yet, and that was called Tai Chi and yoga. It was my first experience with using movement and breathing and meditative aspects all combined together in one. And what I realized when I was being taught how to do yoga and how to do Tai Chi is that there was a formalized way of teaching something that I had stumbled upon as an elite athlete. And that was how to use movement as a way to learn about my body and to use it in a way to get into what we often call, as elite athletes, a state of flow. And I realized in those moments that there was something that I could be using in my profession to teach cancer patients, not just elite athletes. And so moving forward, that was a pivotal point for me where I decided at that point to go back and do my PhD and focus on really mainly working with mindfulness-based forms of movement. However, I do a lot of research also with traditional exercise, but that's not what I'm trying to talk about today. My true passion is my passion with yoga and Tai Chi. So thank you for giving me the platform. So I want to take a moment before I launch into the studies that we've done to talk about the University of Rochester Cancer Center and core research base. I don't want to shine the light totally on our research base because you guys are the home to another research base in the country, Energy. Dr. Bruner is here. And I have to tell you, as I told her at dinner last night, I take my lead in leading the URCC and core research base from what I learned from Dr. Bruner early on in my career and the work that she's done in energy. For those of you that are researchers here at Emory, you have a fantastic resource that you should absolutely be tapping into if you're interested in any type of cancer control research. It's a wonderful opportunity. It's a way to not only bolster your effort to do pilot work, but it's a chance for you to plan early on how you may in fact eventually become a PI of a landmark trial that's a nationwide trial that will indeed impact the future of cancer care. So I encourage you to really think about working with your research base here because this is working with this research base and now leading it is what's allowed me to do the type of research I do and have the impact that I've had on the field. And in short, it's basically a network of scientists with the hub in Rochester, New York. And those scientists work with a wide variety of community oncology practices all across the United States. You can see the little red dots. Those are sort of like the hubs of each of those community-based organizations. And each of those community-based ENCORE sites have anywhere from 10 to sometimes upwards of 100 subcomponent sites, geographically distinct, which translates into more than 3,000 oncologists across the country and more than 1,500 geographic sites where you can actually do your research. It's quite amazing. And this is actually the platform that I'm going to use when I talk about my two large trials. They were conducted through this network. So I'm going to talk a little bit about my yoga intervention that I developed before I launch into the trial designs and the results. When I first started this work, I wanted to develop a yoga protocol that actually incorporated all the aspects of yoga as it relates to postures, breathing exercises, and mindfulness. Coming from an exercise science background, I saw a lot of yoga becoming implemented in the United States that was really focused on the postures. And I think in the true sense of yoga, we don't consider it yoga if it's not fully integrating all of these components. If it's just movement without focusing on breathing and mindfulness, it's really calisthenics, or what we would call in the Western world, exercise in many instances. So for me, as a junior person developing this, I really wanted to make sure that those three things were fully integrated into what we were doing. I also pulled from gentle hatha yoga and restorative yoga in order to create the protocol that we use. And I decided to make the intervention last 4 weeks. And many people still ask me today, Karen, why did you only do it for 4 weeks? And the reason that I only do it for 4 weeks is because when I'm trying to use yoga as a therapeutic modality to treat a sleep disorder or to treat fatigue or to treat some type of pain for a cancer patient, if I can't get the yoga to work for them and for them to have some benefit very quickly, within a week to 4 weeks, I'm going to lose them to pharmaceutical products. They're going to go take sleep medications. They're going to go try other things for their fatigue. So while you think of yoga from a public health perspective and you want people to adopt it and to integrate it fully in their life for a long period of time, when we use it as a therapeutic modality, we're very interested in those short-term outcomes, just like you would be with any other medical modality for treatment. Our sessions are 75 minutes and they're 2 times a week. And we encourage home practice. And in every trial we've done, our participants have indeed adopted home practice. We used a yoga consultant who worked with me to develop this, who was also a cancer survivor. When we do this across the country, we hire Yoga Alliance certified instructors who already know how to teach yoga, and we teach them our specific protocol. And we provide participants with kits that include mats and straps and blocks and bags and manuals and all the things that they need in order to do this. And historically, when we started this years ago, we were still using DVDs, which we don't use now. We've moved on to other modalities for providing that. This is our intervention. We've studied this intervention in 2 large phase 3 randomized clinical trials. And in the first clinical trial, where we tested the original 4-week version of this, we compared it to standard survivorship care. So these were patients transitioning off after a surgery, after their chemo, after their radiation, and we would get them in about 1 to 2 months after they finished. They had to present with a sleep disorder that they were interested in having treatment for. And at that time, standard survivorship care did not involve all the wonderful guidelines that we have now for survivorship care. It was sort of ring the bell, shake your hand, thank you very much, we'll see you for your checkups. Moving forward, the second trial, after we had success in the first trial, we actually decided now we're going to compare our yoga intervention to a rigorous behavioral placebo. And the way that we designed our behavioral placebo was to make sure that we included no physical movement, no breathing exercises, and no mindfulness exercises. But we actually did a survivorship health education program, which I'll explain. And then we also compared it head on with what we knew to be the strongest, most effective behavioral intervention for insomnia, which was cognitive behavioral therapy in the second trial. And the last component that we added was not only immediate assessments post-intervention, but we wanted to see how our participants were doing 3 and 6 months later. So I mentioned that we developed our behavioral placebo, and what we did to do that was we went straight to the ASCO Survivorship Health Education recommendations, and we used their pamphlet, and what we did is we developed it into a course with the content from that manual expanded. We had lectures, and those lectures occurred at the same time. We had 8 sessions just like we did for yoga. They lasted 75 minutes. It was actually something that turned out to be something that we still use in our cancer center today because the curriculum is so good, even though it was a behavioral placebo for yoga. Our cognitive behavioral therapy for insomnia intervention was based on an intervention that is widely used by the VA across the United States. It's standardized. It uses all the traditional components of CBTI, which is sleep education, sleep hygiene, cognitive behavioral therapy. They used a detailed sleep diary monitoring. Our interventionists who delivered this were actually professionals who were certified in CBTI. And again, you can see that we had a lot of ways of standardizing this, but the one thing I do want to mention is that we delivered the CBTI over 8 weeks, not 4 weeks. And it was once a week, a 90-minute session. And some people ask, well, why isn't that exactly matched to the yoga intervention? It wasn't designed to be a behavioral placebo. like the health education group was. This was designed to be a comparative arm, the best treatment that we have compared against this new treatment. And so we delivered it exactly the way it was recommended in the guidelines to be delivered. So I always like to talk about compliance and adherence because people always wonder, you know, will people actually do yoga and what will that look like? So on average, across both of our studies, our participants attended 6 out of 8 of the sessions that were provided. When you and by the way, we did not offer makeups. We really wanted to see if you were given 8 sessions, would you go? When you look at a normal healthy population that's not recovering from treatments for cancer, and you provide an 8-week program to individuals who are walking around without battling this chronic disease, 6 out of 8 classes is considered very good attendance, even in a healthy population. 86% of those who attended, you know, the classes would attend at least 5 or more of the sessions. So when we looked at yoga compared to our health education, we had fewer, and also CBTI, we had fewer participants who withdrew from the yoga arm than the other 2 arms. And one of the things in the industry that many people don't know about CBTI is that a lot of patients don't like it. They find it very hard to follow because it involves sleep restriction. So if you're a cancer patient recovering from your treatments, one of the things they're going to tell you in CBTI is don't take naps too much, and if you do, don't take it for longer than 15 minutes. You can imagine what that might feel like for a person coming off treatment to hear that and to try to adhere to. It'd be very challenging. And we were actually told in our data that part of the reason people withdrew from the CBTI intervention was because they didn't like it and found it hard to adhere to. So what we learned in our trial sort of reinforced what we already had been hearing and seeing in the literature. At the end, we asked people if they found the yoga intervention helpful and useful for their insomnia and would recommend it to others. And overwhelmingly, they all said yes across both trials. So what did we learn from our trials? What I've done is I've combined data on certain outcomes from both of the trials rather than going all through one trial and then all through another trial. So one of the first take-home messages we learned is that yoga improves sleep, without a doubt. In our first trial, we saw that it improved overall sleep quality, it decreased daytime sleepiness, and participants on the yoga arm reduced their sleep medication use compared to standard care controls. And in fact, the individuals on the control arm increased their sleep medication usage during that time, and they did not have the same magnitude of improvement as those in the yoga arm who were reducing their meds. So that was a tremendous finding. Surprised me, actually, as the PI, my first study there. In their second study, when we compared it to placebo, you can see the data here. And here you can see that yoga significantly improved insomnia at all 3 time points compared to our survivorship health education placebo condition. We also utilized actigraphy in both of these arms, or both of these trials. And basically the take-home message is that when we used actigraphy to assess a wide variety of objective outcomes in sleep, you can see that the yoga arm significantly improved sleep efficiency compared to the control arm in the first trial. And there was a baseline interaction. So as you might expect, the lower your sleep efficiency was when you entered the trial, the larger the magnitude of improvement. And then in our second study, we see a similar pattern where yoga participants sort of maintained the sleep efficiency they entered with, while control participants worsened their sleep efficiency. So I mentioned that we compared yoga to CBTI in the second trial, and we designed this trial in an effort to try and establish non-inferiority. And what this means is we did not design the trial to demonstrate that yoga was superior to CBTI. We wanted to know if yoga was not inferior to CBTI. CBTI, when it's done, has tremendously large effect sizes. That's why it is the gold standard recommendation, even above utilization of pharmaceuticals. However, as I mentioned, it's difficult to adhere to. And if we were able to establish that yoga was not inferior to CBTI, it doesn't necessarily have to be better than CBTI. It would give patients two options. If you'd like to do CBTI, great. If you don't think you want to do it and you can't adhere to it, here's another option for you. So I always like to tell people what it takes to establish non-inferiority, because I had to learn this myself when I designed this trial, and it wasn't easy. So the first thing you have to do is you have to define an a priori non-inferiority margin. So rather than comparing our findings to 0, we actually compared our findings to a non-inferiority margin of 1.15, which essentially means as long as yoga participants were not less than 1.15 worse in the outcome than the CBTI participants, we would deem them to be equivalent. Participants have to be blinded. We used a blinding, and we blinded individuals to our hypotheses. Obviously, they're going to know what arm they're in this behavioral trial, but they were told we have 3 really wonderful options for treating your insomnia. When we enrolled them, we did not tell them which one is known to be the best. We did not tell them which one what we hypothesized, but we have 3 different things to offer you for your insomnia. And we did debrief them at the end of the trial, so they would actually know what the intent was. You have to have an active comparison. You have to use analyses of intent to treat, but then following that, you have to use per protocol analyses, where you go back and you actually look at only the participants who adhered exactly to what you asked them to do. So it's all comers, whether they did what you wanted them to do or not, based on the arm they were randomized to. And the second one is you take only those that actually completed the full prescription. And they have to concur. Because even if you think something is good for someone, if your data demonstrates that if they don't do them, your findings fall apart, that's a problem. And what you do to determine your findings is there's really no magical statistical analyses. You plot the means and the 95% confidence bounds, and you look to see whether they cross your inferiority margin. So what did we find in our trial? Essentially, if you look at all the lines with the blue dots, you will see where the intent to treat analyses fell out. And you will actually notice that none of the tails on all of the lines with the blue dots cross the non-inferiority margin. What this means is that per intent to treat, yoga is inferior to CBTI. However, when you look at the per protocol analyses, every single one of the tails cross the non-inferiority margin. But what doesn't happen is those 3 yellow magic dots don't cross the non-inferiority margin. If they were on the other side of the margin, we would know for beyond a shadow of a doubt, yoga is not inferior to CBTI. But what these data give us is what we call inclusivity. So we're not able to say that it's worse, and we're not able to say that it's not worse. But when we think about this data and we put it together with the fact that offering yoga to patients who are getting nothing and offering yoga to patients who were getting a rigorous placebo, we still believe that there is good effects in terms of yoga on sleep. So at this point, what we believe that this data shows is it's inconclusive as to whether yoga is or is not inferior to CBTI. And we would suggest clinicians offer both options. Just a little sneak preview. These results came out and we're working on getting them published. Yep.
So you showed earlier that the compliance to all of the sessions was only a minority of patients, while most people did 5 or 6 of the 8 sessions in a previous study. In this study, how
So
many?
it would be the majority of patients. So more than 8, I believe it's, so the majority of the patients did the majority of the sessions for yoga.
Right, but how many people did all 8 sessions?
So if I remember correctly, that number is about in the 60% range. Which if you actually look at comparing those numbers to, again, people who don't have cancer and are not surviving of cancer, that's actually a really good number. For most people who join like a yoga studio and they want to go do a 4-week or 8-week program on yoga, many of them miss far more of those classes and many actually never even complete the program. So we feel like, given this population, it's good adherence. But I think the take-home message from this is, and I was just about to say, it would give you sort of a sneak preview of the updated guidelines for treating fatigue. It's not sleep, but the similar results hold true, I think, for sleep. It's really both of these interventions are recommended for treating a variety of toxicities these days. And the key here, and the key take-home message here, is have a conversation with your patient, because if they're more likely to want to try yoga and do it, and it's accessible to them and available, you might try yoga instead of CBT. And if they say, no way, I do not want to try yoga, that is not for me, I'd rather go sit in a classroom, hear some lectures, work on my sleep hygiene, and do that, then that's the right option to offer them as a clinician, at least as a starting point, to see what would work for them. So we also were able to demonstrate in the first trial that our yoga, so those were our primary outcomes in both trials. And now I'm going to talk about some secondary outcomes that we looked at, and some work that some of my trainees and junior faculty have done with this data. So we demonstrated in the first study that yoga improved fatigue, and you can see that it virtually improved it across every single subdomain on the on the MFSI, which is actually really important. So not just global fatigue overall, not necessarily just the physical domains of fatigue, but it also helped with mental, emotional fatigue. This was a wonderful finding done by Dr. Lin, a member of my team. And then fast forward into our second trial, and she saw the same thing, and we saw that these effects lasted in a statistical trend for these effects lasting into the 3rd month. Importantly, we don't offer any additional classes when they were done with the 4 weeks. What we see in our 3-month data and our 6-month data is just what happens to patients after they're done with that 4-week time period. And we do have a significant proportion of them who went on to continue doing yoga during that time. I think if we had more formalized programs to assist them with maintaining that, we would see very strong results all the way through 6 months. But that wasn't the way we designed this trial. We've also started to get interested in the fact that a lot of these side effects and toxicities and patient-reported outcomes are sort of, they all co-occur, and we think they're interrelated in some ways. So Dr. Lin was very interested to see, how does changing the sleep influence changing fatigue? We often think if you sleep better, it will take care of your fatigue, right? Or if you take care of depression, for example, it'll take care of your fatigue. What we learned in her analyses is that only 22 to 37% of the changes in fatigue are related to improving sleep quality and reducing daytime napping, which means that leaves, 42% that leaves 63% or more of the information on why fatigue is changing due to yoga up for debate. We need to figure that out. She also was able to show that yoga improves the interference of symptoms with walking, physical activity, and quality of life in her work. And then she also was interested, well, everybody thinks if we lower fatigue, it's going to improve a patient's ability to do functional things and mitigate the issues with function. And what we saw in her data here, and I do have a typo here, but the range is 45 to 53% of the improvements that we see in walking, physical activity, and quality of life reported by these patients are due to reducing their fatigue. So while that's good and it seems like a lot, we still have approximately we have another 50% to figure out. A couple other things, there were a wide variety of outcomes that we've seen in our data. We basically saw an 18% reduction in anxiety in our first trial compared to controls who only had a 4% reduction. We saw a 45% reduction in mood disturbances, while control subjects only showed an 11% reduction over that time. And then I had another colleague of mine who was very interested in pain, especially among survivors at the time, breast cancer survivors taking aromatase inhibitors and tamoxifen. And so he selected only breast cancer survivors who were using these two therapies, and he wanted to take a look at pain and arthralgias and a variety of other things. And what Luke was able to demonstrate is that there was, in fact, a significant difference between control participants and yoga participants on overall pain if they were on aromatase inhibitors and tamoxifen, where the yoga participants actually showed a significant, in a case of aromatase inhibitors, significant differences on reports of pain. And tamoxifen, you can see that the trend is there, but we obviously didn't have enough power to really demonstrate that finding. He saw a similar trend with muscle aches among the same population. Another person who was junior faculty at the time, no longer is, actually was interested in looking at cognitive impairments, and what she looked at here was the effect of yoga on memory difficulty. And again, you can see that the yoga participants report significant improvements. So going down means they have less memory difficulty compared to control participants. And moving forward into the most recent findings of the trial, we see similar kinds of profiles when we look at concentration, memory, and attention difficulty. In fact, one of the trials that we are looking at planning right now as part of a PO1 is actually the effect of yoga on cognition. So many people say, after you've done that, Karen, what are you going to do next? And where do you take this? And there's a wide variety of places to take this line of research. We can always continue to look at other toxicities. We haven't examined things like peripheral neuropathy, other metabolic issues that we have not really examined with yoga in large definitive trials. But I became very interested in the concept, and COVID sort of helped push us into this arena of, could we actually do virtual yoga? We have an integrative medicine center, and our entire integrative medicine center went online during COVID. And so this provided me with an opportunity to take yoga online and do some research with it. And we did a two-arm trial with this particular group, and we enrolled 42 individuals, and this was just our feasibility data in order to deliver this using our HIPAA-compliant Zoom platform that's hosted by our medical center. We had an amazing number of people sign up. It was almost like as we were offering it to people, they were saying yes before we could finish the sentence. And again, taking our lead from what we were doing during COVID, we decided to make this a fully digital, decentralized trial, where a patient never had to broach the doors of Wilmot for us to do this trial. And I'm very excited to say that, I know you are also an NCI designated cancer center, just as an aside, we're working towards that. But this trial allowed us for the first time to show that we could sit in Rochester, New York, and recruit patients from clearly the other side of the state of New York in our catchment area without ever talking to them. We could enroll them in a yoga trial, they could complete it, and they could have amazing outcomes. And that's exactly what we did. We partnered with colleagues at another medical system, and we were able to offer this to their patients. So all of our consents were fully remote and online. We never saw the patient in person. We partnered with them. We used MyChart. To communicate with the patients for recruitment. We used the medical records in order to screen patients that might be eligible as survivors from both healthcare systems, and coordinated that in order to reach out to them to recruit them. They did everything remotely, all the consents and everything, once they decided they wanted to do the trial and they were eligible. All the Zoom was completely delivered all the yoga was completely delivered online via Zoom, and we used RedCap to do all of our assessments in the trial. I will note that we didn't do functional assessments in the trial at the time. It was all patient-reported outcomes via RedCap. But now, moving forward, we've set up an entire cadre of functional assessments that we can also do remotely with patients in their home without ever leaving the house. So this was something that I'm really excited about. And you can imagine we're burning up the papers right now working on this grant. And I'm also excited because I think this type of research has the potential to completely alter what we're doing in the NCTN groups and what we're doing in the NCORE groups across the nation for clinical trials in cancer, whether it's a treatment trial or whether it's a cancer control trial. I think this is something that fast forward 20 years from now, it's going to be an automatic way of doing business almost. Patients loved it. And we even had a patient that found out about us from Florida and contacted us and asked if they could enroll in the trial. And I had to go talk to my IRB to make sure that I wasn't doing something wrong to enroll them. So just to give you and we did enroll them. So just to give you a sense, it really has potential for far wide reaching, maybe potentially even international reach. We learned, so this is just preliminary data. We have a lot more outcomes to look at for this, but one of our outstanding undergraduates did this work along with one of my postdocs, and they were able to show from this trial that we, again, significantly improved the amount of insomnia that patients were reporting. And sleep satisfaction should actually be sleep dissatisfaction. We improved that, and we improved their worry about their sleep patterns in the yoga group, much better than in the control group. And then we also looked at pain. And you can see that we have amazing findings there with the standard care arm reporting increases in pain while the yoga arm reported reductions. So this seems very promising as a delivery platform. So you know that I mentioned that changes in these other toxicities didn't explain all of the story behind why yoga improves these side effects. I think if you know much about any of the literature on toxicities and side effects stemming from cancer, almost every single one of them blames inflammation, right, at some level. And naturally, we thought, well, if that's the case, maybe one of the ways yoga is working is through inflammation. And what I want to share with you today is we did what everybody else has been doing for a long time, and we looked at all these markers independently in our data. And of course, we found these like wonderful, this one, yes, there seems to be a relationship, that one, no. And we wanted to try to make some sense of the process of inflammation as a whole. And so I was excited because this study allowed us, the second study was the first time that we had a large enough amount of samples. And we had a large enough, we had collected blood in that trial, whereas we didn't in the first trial. And we analyzed all these wonderful biomarkers. But with the number that we had, we were able to do path analysis. So we grouped all of our pro-inflammatory cytokines together in our path analysis and did an analysis of pro-inflammatory status and anti-inflammatory status. And I was very delighted to see that my hypothesis was correct in that, in fact, yoga does have a significant impact overall in terms of lowering inflammation, but also anti-inflammatory status. And so what we did is we then combined both of these together, because I've always theorized that it wasn't just one or the other, but it was about the balance between those two processes. And sure enough, our overall model actually shows that, and shows that on the right, shows that yoga actually has a significant reduction, or significantly lowers overall inflammatory status compared to placebo. So that was very exciting. Dr. Lin is currently working on publishing that manuscript. So another area that's always been very interesting to me is circadian processes and circadian phenomena, because it really is a phenomenon in the body that controls and regulates almost every other system and metabolic process. Typically, we often think of sleeping and eating and light as ways of perturbing metabolic processes related to circadian rhythms. But what many people don't know is next to light, exercise is one of the strongest ways that you can perturb that system. You can either dysregulate it by being too sedentary, or you can regulate it by being active. And so our hypothesis was that maybe yoga, this is one of the ways that yoga has these widespread systemic effects across a person's entire body. And when you think about that, it's not really far-fetched, because we know that the circadian rhythms are governed by the suprachiasmatic nucleus, and that downstream they have effects on all kinds of things. Physiological rhythms like cell regeneration, hormones, cortisol, wide variety of things, and then behavior, things like hunger, eating, sleeping, and moving. So in the first trial, we used actigraphy. And I'm not going to show you that data today because I want to spend a little more time showing you the genetic data that we have. But it gave us an indication that yoga did in fact regulate the circadian rhythm patterns of physical activity in these patients that they did outside of doing yoga. But I had the opportunity to work with a very talented recruit that we recruited into our biomedical molecular genetics department at Rochester. And he is an expert in circadian clock gene expression, but he really studies it as it relates to cancer itself and the tumor. And what he was able to do is to develop this thing that we call the circadian clock distance. And I want to take a little bit of time to explain what this marker is and what it does. So at any given time, we have a list of what we know to be our genes related to circadian rhythms. And if you were to take a snapshot in time and you look at the little waves on the left-hand side here of the diagram, there's an expected signature or relationship between the expression of all those genes that regulate circadian phenomena in the body. And we know what a healthy signature looks like, right? So we would expect the relationship to be fully correlated. And if you were to calculate that and show a correlation matrix of those genes, it would look very well defined, like that correlation matrix on the right. And what you would expect to see, if these genes do in fact drive the ultimate behavior of sleeping, is that in people with poor sleep, this matrix would be poorly differentiated. And it would not be such a nice white line right down the middle with such clear and crisp and bold orange and purple spaces, right? So this marker was actually developed by Brian and a colleague of his, where they took over 9,000 tumor and normal tissue samples, and they actually calculated the clock. And the tumor samples that they took were from individuals with lung, breast, colon, and liver cancer. And what they did find is that, in fact, in individuals with these types of cancer, this circadian clock distance was poorly differentiated, right? So the take-home message there that they were thinking from a basic science perspective is cancer, specifically the presence of a tumor, disrupts the expression of these circadian rhythm genes. Well, in my work with survivors, I couldn't go back and get tumor. And I could not necessarily take tumor from someone and then fast forward and then put them on a yoga intervention. So what we did is we went back to Brian and his colleague, Dr. Huey, and we actually said, can you do the same thing with these genes using data from RNA-seq from the blood and using RNA-seq? And so what they did is they actually went back and they used the same methods that they used for calculating this, creating this biomarker from tumor tissue, and they did it in the blood. And so I'm happy to say, I think we are still the first people in the world to do this work. We went into my yoga data with the blood samples that we had. We did get the RNA-seq data, and we then fast forwarded and we calculated their circadian clock distance off their RNA-seq data. And what you can see here is what these matrices look like in cancer-free good sleepers. So this is what good sleepers look like. So many of us who maybe you don't have cancer, if you were a fairly good sleeper, you still have a somewhat less differentiated matrix than if it was the perfect scenario. But none of us as humans would have that perfect scenario, right? But if you look at our survivors who are reporting insomnia, there's almost virtually nothing there, right? The pattern is completely poorly differentiated. There's really no clear separation of direct versus indirect correlations in the matrix there. And in fact, you can see that there's a significant difference between these two matrices. We were also
Patients who have persistent or recurrent cancer versus those cancer survivors or cancer-free.
we haven't done that analysis. In the second study, we included people who went beyond, so I'm not sure we have enough power to do that in the current data, because we did include women who went up to 10 years post, or survivors who went up to 10 years post that had sleep disorders. But majority of our patients are patients who fall within that first year to 18 months who went on the trial. So I'm not sure that we would be able to go far enough to say, especially given that like 75% of them are breast cancer, that we could say they were sort of beyond the curative window. So I don't know that, we don't know the answer to that question. But we were kind of interested in what does the change in this circadian clock distance marker look like in the yoga group compared to the other two groups. And really what you see here is the line in the middle sort of tells the story. None of these were significantly different, by the way. So I just say that right off the bat. We weren't powered to do this. This is really just hypothesis generating data. This is something that I know Brian is going to work on getting an R01 in order to do this in lots and lots and lots of samples to see if our hypothesis really holds true. But it does appear, at least in the shape of what we see, that yoga has the biggest impact on this gene expression compared to cognitive behavioral therapy and our health education intervention. There's also another trial, and I don't have time to go through all of it, but I wanted to tell you we've also done a partnered yoga. And we did a one-arm trial with that, where we actually have survivors coming in with a partner of their choice. It can be a romantic partner, it can be a friend, it can be a family member like a child or a parent. And we basically see the same kinds of results. It works really well. One of the things I do want to mention about our partnered yoga is that our partnered yoga is pretty much characteristically different from anything else out there that's published with partnered yoga and caregivers, in that we didn't simply have them come to class as a buddy. We chose to be a little more brave and daring to see if we could actually go into this space where they really are partnered. So there are times, for example, when we have them doing certain postures and poses and activities where we actually, they're touching each other. So in fact, like Shavasana is a great example. We invite them in Shavasana to hold the hand of the partner that they came to class with. We have them at certain times when we're doing things like tree pose and stuff, or different activities where we invite them to face each other and do it. So we're really encouraging that interaction between them. And the results are phenomenal. And the amount of social support and dyadic partner support that they get from that is through the roof. And so one of the things that we're hoping to study with that in the future is whether or not we can increase that type of support for patients using yoga as a modality. The list is very long in terms of the things that yoga improves. And I give a lot of credit to the colleagues who have also published a lot of data off these trials that I've done, particularly Dr. Lin and Dr. Altman. And I venture to say that if we had a pill, we would give it to everybody. So I think the future of yoga and some things that are really important have a lot to do with, now that we know this works, how do we get it out there, and how do we get it in the hands of people? And how do we help practitioners understand how to recommend it and use it? And I hope that some people who are far better at dissemination and implementation research than I am will take this up and do this work. I like to mention that yoga is now recommended in almost virtually every guideline for cancer that's out there, both across the United States and internationally. And I always love to mention the fact that in response to this, I was able, in fact, to get our cancer center director to open one of the first integrative oncology programs in the western part of New York. We opened ours before Roswell. I love to say that. And it's amazing because we offer yoga and Tai Chi and a whole wide variety of many things that I know you guys also have here in your center. And we were, in fact, one of the very first exercise oncology programs in the country to open. And although some people will say they don't consider yoga exercise, I do. I believe these things are movement modalities and they're all related. And that if we even taught people to be more mindful about their breathing and what they're thinking about when they're out for a walk, we would have a much larger impact. So what I tell people when they ask me right now, there's lots of variety in terms of what a yoga prescription could look like, but I base it off our data. And so I say that you should use things like gentle hatha yoga and restorative yoga. That's pretty much what's been tested in every single study out there. We have not tested things like Ashtanga. We have not tested a heated vinyasa flow or Bikram. Those things are not something that we can make good evidence-based recommendations about for patients. The programs that tend to work tend to include all three components of asana, pranayama, and mindfulness. Ours lasted, people really were participating in the yoga anywhere from 60 to 75 minutes per session. They did do one extra session on their own every week, usually on average in both studies. So 3 times a week, trying to fit it in. And it really is what we do in the yoga, we do is a low to moderate intensity. So it's really accessible to everyone. In fact, I didn't present it today, but we've looked at the data in individuals over the age of 65 in our trial, some of whom even went up into their late 70s. And they were able to do this without any serious adverse effects in any way, shape, or form, and had great outcomes. We recommend that oncologists and providers provide information regarding the benefits of yoga for managing side effects. You don't have to be an expert in it. You just have to know the experts in your community to refer your patients to who are experts in it. But not every yoga practitioner is an expert in how to work with cancer patients, so try to find them in your community if you can. And we encourage survivors to say yes to yoga, but to do it, to choose wisely the yoga programs that you participate in, start super gentle, progress very, very slowly, and practice very, very safely. That's always important. And work with qualified yoga instructors and talk to your oncologist so that you can be aware of contraindications. Don't be afraid to use props and make modifications. It doesn't mean that you're not doing yoga right if you don't use those things. In fact, you are absolutely doing it correctly if you need them and you use them. What next for us? I'm developing an app that we're deploying into some rural communities in New York where I work in order to do this and provide it via a lot more electronic platforms in addition to Zoom. I am working with a junior investigator who has translated this into Spanish, and we are working with training Spanish-speaking yoga instructors to deliver this. And then lastly, I'm also working with community members in Rochester to create a yoga intervention and sort of culturally adaptive for our Black community. So it's more accepting for them and to try it in there. That's it. And I would love to take questions. I got a lot. Yeah, you went and went up first.
Okay, thank you for this talk, very interesting. So, is there any data from other exercise forms? What if it was just walking together for an hour, 8 sessions in a 4-week period? And is there data that tells us that's not as effective as yoga? Like, what do you think about?
So there's lots of data on other more traditional forms of, I want to say this, I don't want to use the word traditional, more Western traditional forms of exercise that suggest it works. I am not aware yet, if you are, let me know, because I'd like to read it, of a study that direct head-to-head tests a full-on yoga intervention versus a full-on exercise intervention. They've done some things like stretching versus yoga, but that's a little bit different category. And so I don't think we have the answers to that. And I do think I would encourage a couple things. If you're interested in those types of that research, I would encourage you to learn about non-inferiority analyses. Because what you don't want to do is show that one is not superior, and then all of a sudden the field says, throw away yoga or throw away walking. You don't want that, because in the end, the more choices we have to offer patients, the better. And if you can show that, you know, walking's not inferior to yoga, which is actually the way I would hypothesize that study, then you still win, right? You have a win. You have a double win for patients because you have two things that are really effective to offer them.
Thank you for the talk. A lot of great data. Have you looked, 2 questions. One is, have you looked at the effect of yoga or any of these interventions on the autonomic nervous system, particularly things like pulse rate or even subtle variations in the pulse interval, because that's something that can be captured electronically today very easily. And a lot of the effects on sleep, fatigue, everything else are going to be manifest in the autonomic nervous system.
We have,
The second question is, the effect is quite sticky. I mean, you're seeing persistent effects at 6 months after intervention of 8 sessions 5 months earlier. Did you have any look back on those subjects, whether they continued any type of practice in the interval?
they did continue some practice, but as you would expect, not everybody continues a really robust practice. And the 6-month data, the trend is there, but you see that same pattern, but it's not even a statistical trend yet for the magnitude of difference. And the 3 months, there was still a trend. Like I said before, I think if we did just some simple like boluses, like boosts with people, it might help them maintain it. And the other thing I think about that is what we learned from exercise a long time ago is it's not that people aren't going to stop. Everybody is going to stop exercising or a yoga practice at some point for some reason. There's no sort of what we would call perfect human who does it all the time, every time. And if they do, they're a micro proportion of society. And so the key in that becomes for sustained recovery, sustained wellness, like warding off late effects and things like that, right? That we might think about is not how to get them to not stop, but how to figure out a way in terms of behavior to recognize when they do stop and to shorten the amount of time in which they stop. So you don't want it to become, you know, maybe it's a month. I mean, even elite athletes stop training for a month or 2 at different points in the year to give their body a recovery, right? So when they do stop, how to put a break on it, right? Like how to get them back into it within a reasonable amount of time. And what is a good amount of stop? Maybe a month is a good amount of stop if everything goes crazy in your life or you're ill or something, but then maybe you need to make sure you get back on the bike, so to speak, from that. The autonomic piece, we have not measured in our trials, but we have started working with Bodyguard, and we're potentially interested in deploying them out into the field and having patients use Bodyguard to look at heart rate variability. And I'm actually looking across lots of wearable devices and things that we don't have to bring them into a lab to measure that. So if you have any ideas, I would love to hear them. You had a question?
I did. I wonder if we are out of time, but I wonder if you could just speak to measurement, because you make references to things like they found it useful and recommended others, or you call them good sleepers and people who reported insomnia. Are you actually measuring duration, REM, light, deep, wakefulness? I mean, are there real?
So we don't do polysomnography, not even like remote polysomnography, but we do actigraphy. And so in actigraphy, you can look at sleep efficiency, sleep latency, sleep duration, wake after sleep onset objectively. So we did that, and I presented only the sleep efficiency data, but we do see improvements in some of those other markers objectively. When I talk about people being good sleepers, I'm using validated and reliable patient-reported outcomes. So things like the Insomnia Severity Inventory, the ISI, or the PSKI, which is a sleep quality measure. These are things that are recommended not only in the world of oncology, but across the board in terms of people who study sleep, to get patient perspectives. And we always try, every time I can in a trial now, I try to have some type of patient-reported outcome and some type of objective measure. We find actigraphy to be super easy. We've gotten very good at putting the actigraphs on their wrist. The companies know me now because I call and order them 800 at a time. And they're like, whatever you want, Dr. Mustain, we'll give it to you. You want us to fly over from Europe? We will do it. So we do a lot with actigraphy.
Chat, and we can kind of summarize it as wanting to know more about designing the exercise trial and specifics about the non-inferiority trial, the sample size in particular, and implementation. How did you go about identifying and engaging the yoga team to deliver?
Identifying and engaging the yoga team, so the instructors, to be able to produce this nationwide trial meant I spent a ton of time talking individually to people on the phone all over the country in the first study, and in the second study it became Zoom and other platforms like that, where I personally and members of my team did one-on-one with those instructors to make sure they knew exactly what we needed them to do. The community members and the encores helped find the people who were living in their communities in order to engage them. And what's nice about that is there are some communities who did these trials, and now they actually know these instructors in their communities to refer patients to. It was hard at first because it was a little outside the realm of what a traditional oncology office would have looked to do. But that's also one of the things I love about doing research in the NCORE network, is if I do something new in the NCORE network that pushes practitioners in those practices to do something different for my trial, they're gonna now know that. And even when my trial is over, if I've connected them with a behavioral therapist that knows how to do CBTI in their community, or a yoga therapist that knows how to do this for their patients, even when my trial is wrapped up and done and I'm long gone, they're still gonna have those resources, right? They're still gonna have that knowledge. And now they're gonna think, oh, maybe I should recommend this to that patient. And then before you know it, hopefully you see it in guidelines, and they're already poised to do this way before other communities in the country are. And was there another question I'm missing? Trial design.
Trial design and more specifics about the non-inferiority trial and how big of an N would be.
So that trial was 730. And that gave us a large enough N to do the non-inferiority. Remember, we had 3 arms. So you can imagine that split approximately a third. So 2/3 of that was enough power for us to power the non-inferiority analyses. You calculate power completely different for that. So if anybody wants to learn how to do that, you got to find a statistician in your group that knows how to do it. feel free to reach out to me. I'll give you everything we have on it. And then the non-inferiority hypothesis is also written slightly different. And I found in getting that grant funded and talking to people, there's an art to writing that hypothesis so people understand what you're doing. Other than that, it looks pretty similar to another traditional randomized trial.
Thank you.
Thank you.
Okay.